Ready, boss. Ready?
Yes, sir.
All right.
This rhythm is SVT. This patient is symptomatic due to the rhythm. I'll treat the patient with the following. BSI, assess the ABC, secure the airway. O2, IV monitor, pulse ox, vital signs, patient history, physical exam, 12 EKG. Additionally, I would treat this patient with vagal maneuvers. If that were ineffective, I would give this patient 6 milligrams of adenosine, rapid IV push. If that were ineffective, I'd give the patient 12 milligrams of adenosine, rapid IV push. This rhythm is a third-degree heart block. This patient is symptomatic due to the rhythm. I'll treat the patient with the following. BSI, assess the ABC, secure the airway. O2, IV monitor, pulse ox, vital signs, patient history, physical exam, 12 EKG. Additionally, I will not rely on atropine to treat this patient. I will immediately transcutaneous pace the patient. If that were ineffective, I would hang a dopamine drip at 2 to 10 micrograms per kilogram per minute. This rhythm is BTAC with a pulse. This patient is unstable due to the rhythm. I'll treat the patient with the following. BSI, assess the ABC, secure the airway. O2, IV monitor, pulse ox, vital signs, patient history, physical exam, 12 EKG. Additionally, I will treat this patient with synchronized cardioversion at 100 joules biphasic, increasing in a stepwise fashion as needed. Prior to synchronized cardioversion, I'll check the patient's O2 stats, prepare my suction equipment. I have an IV established. I'll prepare my intubation equipment, consider sedation for the patient, and deliver synchronized cardioversion at 100 joules biphasic, increasing in a stepwise fashion as needed. This rhythm is sinus tachycardia. This patient is suffering from pulmonary edema. I'll treat the patient with the following: BSI, assess the ABC, secure the airway. O2 IV monitor, pulse ox, vital signs, patient history, physical exam, 12 EKG. Additionally, I will treat this patient with Lasix, 1 milligram per kilogram. I will also treat the patient with a dopamine drip at 2 to 10 micrograms per kilogram per minute to stabilize their blood pressure. If the patient's blood pressure improves, I'll treat them with nitro, up to 3 doses, titrated blood pressure, sublingual. I would place this patient on high flow O2, and I could also treat this patient with morphine per medical direction, rapid transport to the nearest cardiac care facility.
Excellent. And 1 minute, 10 seconds. Fantastic. Your patient's a 69-year-old male who is found unresponsive by the pool bar.
So, BSI,
Okay.
LOC,
Patient's unresponsive.
ABCs.
Patient's apneic and pulseless.
All right, we'll begin high-quality uninterrupted CPR, and I'll place the patients on the defibrillation pads. This appears to be asystole, so I'll have them continue with high-quality uninterrupted CPR. I'll check my cables and confirm it in a second lead. It is confirmed as asystole. We'll continue with high-quality uninterrupted CPR. I'll establish an IV, intubate the patient with high flow O2, and confirm my tube placement. I will also promptly administer 1 milligram of epinephrine IV push. I'll want to start considering my H's and my T's. After 2 minutes, I'm going to perform a brief rhythm check. I see a change on the monitor. Do I have a pulse?
You do not.
We'll continue with high-quality uninterrupted CPR. This is VFib, so we're going to want to defibrillate the patient at 200 joules biphasic, but for testing purposes, I'm going to go to 1 joule. I'm going to charge while we continue with high-quality uninterrupted CPR. 1, I'm clear. 2, you're clear. 3, we're all clear. VFib on the monitor, shock, and resume CPR. At this time, I want to go ahead and confirm my tube placements, and I'm going to hold off on epinephrine because we gave it during our last round of CPR. After 2 minutes, I'll perform a brief rhythm check. I still see VFib on the monitor. We're going to charge to 200 joules biphasic to defibrillate the patient while we continue with high-quality uninterrupted CPR. 1, I'm clear. 2, you're clear. 3, we're all clear. VFib on the monitor, shock, resume CPR. During this round of CPR, I'm going to administer 1 milligram of epinephrine IV push. After 2 minutes, I'll perform a brief rhythm check. I see VFib on the monitor. Continue with CPR while I charge to 200 joules biphasic. 1, I'm clear. 2, you're clear. 3, we're all clear. VFib on the monitor, shock, resume CPR. During the cycle of CPR, I'm going to administer 300 milligrams of amiodarone IV push. After 2 minutes, I'll perform a brief rhythm check. I still have VFib on the monitor. Continue with CPR while I charge to 200 joules biphasic to defibrillate the patient. 1, I'm clear. 2, you're clear. 3, we're all clear. VFib on the monitor, shock, resume CPR. During this 2-minute cycle of CPR, I want to administer 1 milligram of epinephrine IV push. After 2 minutes, I'm going to perform a brief rhythm check. I still have VFib on the monitor. Continue with CPR while I charge to 200 joules biphasic. 1, I'm clear. 2, you're clear. 3, we're all clear. VFib on the monitor, shock, resume CPR. During this 2-minute cycle of CPR, we're going to administer 150 milligrams of amiodarone IV push. And after 2 minutes, I'll perform a brief rhythm check. I see a change on the monitor. Do I have a pulse?
No.
Continue with CPR. This appears to be asystole. I'm going to check my cables and confirm in a second lead. It is confirmed as asystole. We'll continue with the 2-minute cycle of CPR, and I will promptly administer epi 1 milligram IV push. I want to consider my H's and my T's. I'm going to consider hypoxia. I want to confirm my tube placement by also taking breath sounds, and also connect the patient to waveform capnography. Since the patient's been down for a little while, I also want to consider hydrogen ion acidosis. We'll administer 1 MEq per kilogram of sodium bicarbonate. And we'll see if anyone can provide us any information on the patient before he went down. After 2 minutes, I'll perform a rhythm check. I see a change on the monitor. Do I have a pulse?
Negative.
We'll continue with the 2-minute cycle of high-quality uninterrupted CPR. This rhythm appears to be sinus ready without a pulse. It is PEA, so we'll continue with high-quality uninterrupted CPR, and I will promptly administer epinephrine 1 milligram IV push. I want to consider my H's and T's.
Go ahead and name all of them for me, please.
Yes, sir. Hypovolemia, hypoxia, hydrogen ion acidosis, hypo and hyperkalemia, hypothermia, toxins, cardiac tamponade, tension pneumothorax, coronary and pulmonary thrombosis. We'll go ahead and confirm our tube placement again.
Senator Howard.
Yes, sir.